Great. So let me welcome you all. Good morning, good evening, good afternoon, wherever you're dialing in from. Thank you all participants for joining, and especially our speakers for agreeing to speaking to us and presenting their research today. Let us maybe warm up a little bit with the question to those who haven't yet entered the Menti link to go to the chat. Bethany put into the chat a link with a Menti page where you can tell us where you are dialing in from. It's always fun to see at the end of the seminar the reach we have actually gotten and the reach our presenters obviously have gotten. I'm very excited to be moderating today's research seminar, given the focus on geography and the application of geospatial methods. Because I think if we only look back a couple of years, geospatial analysis was still really in its baby steps and was not yet really used to identify disparities in development, especially in health. And so I think geography is so very important in determining if or if not someone or certain groups of populations are actually at risk of being left behind. So I'm really looking forward to the conversation today on physical access, also on geographic access, to differentiate a little bit between those two as well, and see how we can actually discuss some of those big factors of vulnerability. And so I'm very grateful for our speakers. You see both of them on the screen. And I'm very grateful for them to be dedicating their research to such important topic. Before we start, maybe just a couple of things on logistics and background on the seminar series as well. So the PGSSC Global Surgery Research Seminar is a public seminar series which aims to share methods and results across a broader surgery research community. And so over the course of 10 seminars, it is our goal to strengthen the general knowledge and specific skills by learning from the experience of our seminar speakers. And in every seminar, we aim to invite 2 speakers from around the world to speak to us on a similar topic with similar methods, but some differences inside, so that we can really dive into their understanding around those. And so that we can really dive into the results, but also the methods, the difference in methods, and try to understand the strength and the potential for integration for both of them. So it's a great learning opportunity. I always enjoy them. I'm always learning a lot from the speakers. We are currently recording. We will make them available after the seminar as well on our site. So we're obviously hoping that you're with us live, because then our discussion can obviously enrich from your experience. But if you're not with us live, we will have all of the discussion and the presentations posted on our websites. The real benefit for connecting online is obviously that we can bridge the geographic gaps and that we can reach a much larger community interested in global surgery and get to listen to experts around the world. So we're also still taking advantage of the very negatives that a pandemic has brought about us. Before I introduce our speakers, I would really like to acknowledge and appreciate the work of colleagues who invest a lot of time and make a lot of investments to get this series off the grounds. And there are numerous fellows and visiting students involved. Beth and Adeline as well from our faculty. For me, Megan, shout out, your preparation for today's seminar for me has been tremendous. So I'm very appreciative of that. But also maybe to highlight that the next speakers for our seminar in May are already lined up. We will hear results from a systematic and a scoping review on the burden of injury, and we hope that you will be able to join us then as well. So maybe with no further ado, allow me to introduce our first speaker and welcome Dr. Tiago Rocha, postdoc associate currently at Duke University, who holds, I'm on the screen of, no, sorry. I thought I'm actually showing Nick while talking about Tiago, but I think I'm fine. You see Tiago, right? You see Dr. Rocha? Yep. Yes, okay, apologies for that. Postdoc associate currently at Duke University, who holds a PhD in human resources for health with a focus on the evaluation of the performance of public policies from the Federal University of Minas Gerais in Brazil. Dr. Rocha has worked as a data analyst and technical coordinator in health projects involving emergency response, epidemiology, global health, artificial intelligence, and GIS, statistical analysis, and also health policy assessments. So Dr. Rocha or Tiago, we are very happy that you're with us, and I'd like to turn over to you for your presentation. Thank you.
Thanks, Sabrina. First of all, I'd like to say thank you for the opportunity to be here today, sharing a little bit of my experience with GIS and how can we use this type of approach to better understand health-related challenges and how can we think about innovative solutions to overcome geographical barriers of access. So the presentation today is organized in two sections. And before starting, I'd like to say thank you for all the organization committee and for the invitation. And my presentation is organized in two sections. First, I will present to you a case study in which we use a GIS approach to try to estimate access barriers in terms of pediatric surgical care. And a second part of the presentation, I will go through a little bit about tools and what are the perspectives and the possibilities to use GIS tools to overcome health-related issues. So for the first part, we did a study in Brazil, and before starting and presenting the results, I think that it's important to try to better understand how the Brazilian health system is organized. So we have a huge country in terms of extension, composed by 27 states, almost 6,000 municipalities, and we have in the Brazilian health system something close to 350,000 health facilities between public and private providers. So all these providers and all these components of the health system are integrated in more than 30 different health information systems that are trying to collect information about hospital admissions, availability of services, availability of professionals, disease being notified in terms of surveillance, and many other topics that I will go present to you in the next slide so you can have an idea of how this complexity is organized to generate evidence for the Brazilian health system. And beyond that, we have a very complex governance structure. So we have three administrative levels in the country: municipality, state, and the national level. And they are all organized following this network structure. So every decision made into the Brazilian public health system is the result of the discussion in each one of these levels. So it is important to keep in mind this governance structure, because every decision made into the Brazilian health information system is the result of conference discussions involving policymakers, the universities, and experts trying to achieve the best results in terms of what will be implemented for the Brazilian population. There is a very good publication describing the organization of the Brazilian health system that is highlighted here. And if you have interest, you can go through this to kind of see the details. One thing that is important too is that the Brazilian reality is very different. So I'd like to say that if you want to try to pilot one idea, Brazil is a very good place to start discussing about this possibility, because we have different realities within the country. Right now in this map on the right side of the presentation, you can see we apply the World Bank criteria for income classification to the Brazilian municipalities. As you can see, we have lower income municipalities highlighted in red. We have upper middle income municipalities in this little yellow color. And we have high income municipalities highlighted in green. So we have different realities in Brazil. So if an idea works fine in Brazil, much probably this idea will work fine in other countries, in other circumstances, exactly because of this difference in terms of the country composition. And Considering this, it's very clear for us that we have disparities between the Brazilian regions. And we also have several geographic barriers of access for health services. Right now, this portion of the country is largely covered for the Amazon forest. And we don't have like urban structure in this region. We don't have roads. The availability of health services is not well distributed considering equity principles. So it's very interesting when you need to try to understand or try to propose solutions to overcome geographical barriers, take into consideration these multiple realities that are present in Brazil, for example. And right now in these two maps at the bottom, we can see the availability of pediatric care considering two levels. This is primary health care. So we can see this, each blue color in the map represents the accessibility index. This index is the result of one geographical technique called two-step floating catchment areas, in which we create some catchment areas for each health facility. And after this process, we aggregate this information to the municipalities to see how much healthcare providers are offering care close to each Brazilian municipality. And considering the primary healthcare availability, we can see that we have large portions of the Amazon region not covered at all for any type of primary healthcare service. And this part of the country is the areas with the largest population. So we have the availability of health services in this part of the country is much higher than in the north portion or northeast portion. This is considering primary healthcare that is based on an idea that offer healthcare services close to the population. When we go for pediatric centers responsible for surgical care, for example, we have a much challenging reality. We have large portions of the country not covered within 2 hours of displacement by 2 hours of displacement in terms of a tertiary level pediatric center with capability to perform surgery. So if you have children here in this area and you have a problem or situation that you're gonna need a high complexity care provided in hospitals, you're gonna have a challenge because there is no hospital available within the 2 hours displacement. So as you can see, this is, if you keep in mind that a policymaker needs to reorganize the healthcare network, trying to improve access for tertiary level care, having this type of information is something that is very important because you can identify where you have demand and where you need to improve access and how can you reorganize your network of providers to try to cover the population in need. So I'd like to say that for everything that location matters, you should use a geographical perspective to try to understand your problem. And when you think about health, location matters for everything. So everything that you need to address a problem or a challenge in health, in the healthcare domain, you should use a geographic approach. And one advantage of the Brazilian beyond this multiple reality is the availability of information. So we have right now more than 30 systems integrated into the country, reporting everything that has been done under the public part of the health system. And several of these systems offer you geographical coordinates. So you can, for example, identify where people that are facing challenges in terms of surgical care, where they are coming from, how they are traveling, to which facility they are seeking for care. So you can use this geographical perspective available into the system to try to better understand flows. And I'm going to present to you how we are using this to improve the capability of the Brazilian health system to take decisions based on that. Okay, so brief panorama about the Brazilian reality and how we are trying to use GIS to overcome surgical challenges in Brazil. So a few years ago right now, we published a study that you can find a link here at the bottom of the page, trying to discuss accessibility of surgical care under the pediatric perspective. Why we decide to do this? We have a Lancet Commission that is discussing surgical care accessibility and defining thresholds in terms of professional density, coverage, thresholds in terms of time displacement for adults. So for the most part of the population, you have the two standards for defined by Lancet, but we don't have a similar threshold regarding pediatric care. So our idea is trying to generate a little bit of evidence so we can foster a discussion of how should be the density of professionals in terms of pediatric care, how should be organized the network of providers in terms of coverage. And this was the idea behind this management. And in the beginning, we have in mind 4 challenges. First, as I presented to you, we have discrepancies between the local needs and the health workforce in Brazil because we have this different realities. In Brazil, the workforce is inequitably distributed across the municipalities. So this is pretty much what.
That's pretty cool. This is
and the need to look for optimal surgical workforce for children remains poorly defined. So we're trying to generate evidence about this. And the 4th challenge was aiming to characterize how is distributed the surgical workforce dedicated to provide care to children. So what we did, we aggregated information from, okay, 5 different systems in Brazil. One system regarding hospital information system. So this system aggregates information about every hospital admission in the country. So we select the procedures performed into the hospital, ICD code, age of the patient, location of residence, costs associated to the procedure. So from 2008 to 2015, we collected data regarding almost 300,000 procedures. We also aggregate information about the mortality data. So we got all the data regarding deaths under 14 years old, the municipality of residence of each deceased person, and the mortality rate for each municipality, and we got information about 300,000 deaths reported. We aggregated the information we also create 2 additional layers. One layer regarding the location of health centers, and especially the tertiary level health hospitals providing surgical care, providing pediatric surgical care, and data from the World Bank in terms of income classification and Brazilian population estimates from the Brazilian Institute of Geography. And by doing this, we got some interesting results. The slides passing too fast. Okay, so right here, each blue polygon represented in this row represents a Brazilian municipality and the pediatric mortality rate. The fact that Brazil has kind of 6,000 municipalities is not clear, and it's not easy to see patterns here. So you can see that we have higher mortality in this region, that is the north region of the country, one of the poorest regions in the country, and exactly where is located the Amazon forest. And we have a different distribution for each age bracket that we are considering. But extracting patterns for this is not easy. So this is why we use one geographic technique that is called Gettys-RG, that is exactly dedicated to create clusters. So every time that you can find a distribution of a variable of an event that is not randomly distributed across the space, this technique can offer you, can highlight to you where is located cluster. So this is exactly what is presented in the second row. So each hot color here represents hotspot clusters in terms of mortality. So we can see that the mortality rates are for the period that we analyze are higher, are not randomly distributed across the space for each one of these red areas that you can see. And the red color means that we have a cluster of values of high mortality rate. On the opposite side, we have the blue regions, that is clusters of cold spots. So these are the areas where we are having statistically significant clusters, highlighting that we have the lower mortality rate into the country. So you can see, and you're gonna be able to overlap this with accessibility of services and health professionals, that exactly these areas facing challenges in terms of high burden of mortality are the areas in which accessing health services is more challenging. There are the areas in which we have the lowest density in terms of professionals, and we are able to kind of get this perspective exactly using GIS tools. And from the hospital information system, we extracted 5 procedures. These 5 procedures are considered the bellwether procedures, are kind of basic procedures that you need to be able to offer to cover satisfactorily surgical care in terms of pediatric perspective. So we have appendectomy, colostomy, hernia surgery, laparotomy, and wall reconstruction. And we can see that the higher each red color represents municipalities, a cluster highlighting elevated number of procedures performed, so adjusted per population. So you can see that the area with the lowest mortality here is the area where we are having hotspot clusters in terms of basically surgical procedures dedicated to pediatric care. And the area with a blue region here highlighting regions with a lower number of procedures performed. So we can see that we have kind of overlap between lack of availability of surgical capacity and higher mortality rates as I presented in the previous slide. And after this, we create an additional layer trying to identify the availability of health professionals. So we took into consideration 4 categories: general surgeon, pediatric surgeon, obstetrician, and anesthesiologist. And they are concentrated in the largest populated area of the country. You don't have a large availability of this type of professionals in the northeast portion of the country. And this is also a region facing challenges in terms of income. And when you took into consideration the 3 categories, you can see they are concentrated in the richest part of the country. And this is kind of generating, supporting the idea that the lack of procedures, the lack of availability of health workforce may be related to the mortality rates that we are identifying to the country. So as you can see, we have an opposite trend between the 2 maps. So higher availability of professional, cold spot of mortality. Lower availability of professional, a hot spot of mortality. So additionally, we performed some statistical analysis to try to identify and to analyze not each municipality as represented into these maps, but also the state level situation. So in this axis, we have the availability of professionals, density of professionals, and in the epsilon axis, we have child mortality. We can see that there is a correlation between higher the availability of professional, lower the mortality rate, and the color represents each region. These are the 2 regions of the country. They're the poorest regions in Brazil. So as we can see, they are presenting a behavior of higher mortality with lower professional density when we took into consideration pediatric surgery. We have the similar trend for general surgery. And we have the same trend for anesthesiologists and obstetricians. So seems to us that is very clear that is a strong association between availability of health professionals and mortality rate. And we are able to identify this exactly trying to getting the insight from the GIS piece of the study. And after this, examining how this relation of, for example, work professional is associated with child mortality. So this was one example. I am going to the main objectives of the study. If you think that this approach can support you, you can go to the manuscript to see further details. And I also I presented this case study to highlight how can you use GIS to kind of generate insight to think about the strategies to overcome surgical challenges. But I think that it's also important to present perspectives. How can you use different tools in terms of GIS to kind of generate evidence? And I decided to separate and to discuss 5 pieces and 5 group of analyses that are useful to try and generate evidence in terms of healthcare domain. First of all is the spatial clustering. Basically, the maps that I present for you are highlighting spatial clusters where you can see where you have a high density of professional, where you can have hotspots of mortality. And basically, the idea of this group of these techniques is trying to assess if a phenomenon is randomly distributed to the space or if this phenomenon is clustered. And there is a geographic rules that says if some things are happening close to each other, there is an underlying explanation for this phenomenon. So if you have clustering, something in this specific localities or something in these specific regions may be contributing to explain the behavior that you are seeing. So this group of techniques can highlight for you if you have hotspot clusters, cold spot clusters, or association. One technique that is largely used is the Moran's autocorrelation. So this technique uses Moran's eye, and is dedicated to trying to identify association between two variables, for example. So you have 4 different outcomes in terms of categories. The category high, for example, this was one study that we used it to trying to investigate Zika patterns and microcephaly. So you can have in this area here, for example, we are having a high volume of Zika cases associated with a high volume of microcephaly. So the Moran autocorrelation compares 2 variables and define what type of clustering can you see. And it's also defined as an outlier analysis because you can find a situation where you can have divergences, for example, high-low cluster or low-high cluster. For example, a low-high cluster will mean that you have a low number of Zika cases associated with a high number of microcephaly cases. So this is intriguing because we know that the possible association between the Zika infection and microcephaly, and why we are having regions that are presenting a low number of Zika cases and a high number of microcephaly cases. This difference may be related to some issue to our health information system or something new that deserves more attention to investigate possible causes associated to this. But this is one technique very interesting because, for example, if you think about availability of mortality associated to lack of surgical care, you can identify if a specific region with low access to surgical services is associated or not with a high level of mortality. And you have the GATS-RD, that is basically the technique that I presented to you that we use for trying to investigate the association between health professionals and mortality and surgical care. This is pretty much gives you only the spectrum of the outcomes is related to 2 specific points, cold spot or hot spots. The difference in terms of colors are related to the confidence of the result that you are getting. So basically you can get this dichotomous result in terms of hot or cold spots associated to the variable that you are trying to use. And you also have the possibility to use the kernel density analysis. The 2 analyses that I presented earlier are dedicated to polygons analysis, so you can analyze regions. And kernel density is more dedicated to analyze points. So if you have, for example, household location of someone that is needing to displace more than 3 hours to get access to a surgical services, you can create clusters of these points to try to identify hotspot areas in which the points are aggregated, not following a statistically significant pattern. So these are pretty much the 3 largest most used spatial clustering techniques. This is, for example, here is the location of COVID case in Brazil for the biological week 16 of 2020. Okay, so spatial clustering. Beyond spatial clustering, you can have space-time trend clustering because for several problems, you need to identify space-time trends because looking for just one point in time will not give you a perspective of how the things are evolving, how the things are changing, which are the locations, for example, if you think about the policy perspective, let's think that you are trying to reorganize your surgical care network and open new hospitals. So 2 years, you're going to be able, the network of providers will change, and you'd like to see how this changes into the network of providers are affecting access to surgical care, for example. So to do this, you need to not just consider one point in time, but compare several points in time. So this is Spacetime clustering does exactly this. So you can compare for each layer into time, you can overlap them and see how things are changing across the time span that you are analyzing. So you're going to be able to identify clusters that are not relevant for one specific point in time, but you can see if a specific cluster, for example, is remaining at the same location. So if you have a phenomenon that is remaining at the same location, you have a strong behavior in terms of access, of lack of access, of mortality, that can help you to identify regions that are presenting challenges in terms of access to services or any other topic. And basically, these techniques, what these techniques create, for example, here is one example in the United States. So you can have like the autocorrelation analysis overlap for each point in time, and the analysis will go to each point in time to try to identify, for example, low clusters that are stable, considering all the points that you are analyzing. And this is very useful to kind of identifying this more stable trends in terms of variables. The second analysis.
Iago, yes. Allow me to interrupt for a moment and just be mindful of time. We have a couple of more minutes for your presentation before we want to give the floor to Nick.
Okay.
Thank you.
And this from this emerging hotspot, for this Spacetime clustering, you can have this emerging hotspot analysis. There was one analysis that implemented NuxJS that will give you 16 possible categories in terms of what the behavior of one specific variable to time. So these are the mainly two categories, the two analytical possibilities for space-time trending. And you also have accessibility analysis. They are based on network ideas. So you can use a network of providers connected by roads or by rivers to trying to create, for example, customized catchment areas that will highlight for you the time of displacement. So this type of analysis is very useful for define strategies to better reorganize the network of care. So here is a work that we did, for example, in the Brazil to trying to identify lack of primary healthcare services, aiming to foster the discussion for COVID-19 vaccination. So every blue point here represents a health facility, a primary healthcare facility, and every color is a customized catchment area created over the network of transportation using roads. So you can see that these are the coverage of each area. And overlapping this with satellite estimate population, we can identify areas facing a lack of primary care. So we have population here identified using the satellite imagery, and we don't have any type of health services coverage here. So if you need to address a health campaign, like for example, an outbreak of measles or try to improve access to care, people living in these areas will face geographical challenges because they are far away from the closest health facility. And you can customize the size of each catchment area depending on the problem that you are trying to address. The work that described this is here. If you have interest in further details, we developed a geospatial tool that you can install and create this analysis just using 6 clicks of mouse and no need of coding, exactly trying to force this type of discussion. Another analysis that is very interesting is the location allocation analysis. So you have a network of providers, you can link the population to this specific network of providers, and you can have some question in mind, okay, where I should open a new hospital to cover the largest amount of population with just 3 or 4 units. And this analysis will provide for you the optimal location where you can add new features to your healthcare providers so you can cover the largest amount of population considering the minimum displacement in terms of distance or time. This technique is known as location allocation. And we can also have the use of network analysis to try to identify the closest facility or origin destination. This is important to try to displace, for example, we're gonna decide where we're gonna build, for example, ambulance stations or how can you better organize your providers in terms of distance that the population is covering to get access to health services?
Iago.
Oh,
I'm sorry, I just have to ask you to wrap up so that we
okay.
have enough time for Nick and then our discussion as well.
Okay, my apologies. So the other two groups, I added some text to the slide so anyone can try to see the explanation for the analysis. I'm not sure if you're gonna share the presentation with the audience, but in my case, you can feel free to share the presentation, because if anyone has some questions or would like to keep this as a reference, they were gonna have the explanation here. So the idea is to kind of explain how can you use these different types of approach to kind of overcome health-related challenges. And I will share the presentation with the organization committee. And thanks for the opportunity to be here today. We are doing a lot of information. We have a lot of studies using Brazilian information system. We have right now like 13 billion data points distributed across several health information systems. So, in most part, several of these systems are offering information geolocated with geographical coordinates, so you can analyze several perspectives in terms of access, in terms of distribution of services, in terms of correlation with social determinants of health. So I think that the availability of this type of information in Brazil is a very rich source to foster discussion associated to use of GIS tools for the healthcare domain. My apologies for the time. So if you like to, these are our partners. If you like to see any further on what is going on from our side in terms of research, you can access the MARC Consortium website. And this is my contact information. And thank you.
Thank you very much. Thank you. Thank you very, very much. I think it's actually been really, really helpful to learn on the array of methods that are available for geospatial analysis to really use or look at location and geography as one of the factors really that put people at risk of being left behind. Geography, location, one of the factors identified also by the Secretary General of the United Nations as one of the key factors of placing people at risk of being left behind. So thank you very, very much. I think it's actually a very nice presentation prior to the presentation now also that we will hear from Dr. Niklas Rudolfsson, who has embarked on an exercise to actually validate some of the geospatial methods with a patient-centered approach. So Dr. Niklas Rudolfsson, he is a researcher and PhD candidate at the WHO Collaborating Center for Surgery and Public Health at Lund University. And he is a resident at the Department of Urology at Kristianstad Central Hospital. He previously worked as a research fellow at the Department of Global Health and Social Change at Harvard Medical School, and as a visiting student here at our program for global surgery and social change as well. His research focuses mainly on financial and geographic aspects of access to surgical care. And we are very excited to welcome you back, Nick. And I turn over the mic to you. Thank you.
Thank you very much. Let me try and share my screen. Am I sharing the presentation now?
Yep, we see it.
Terrific. Let me just try and rearrange. No, that's not the right button. That's
While Nick is rearranging, you see that we're posting again the Menti link in the chat if you want to share where you're dialing in from. So we have that information later on.
Terrific. Thank you, Sabrina, for moderating, and thank you guys for having me. And it's great to see a few familiar faces in the crowd out there as well. And it's great that we right now have 76 participants. I checked the preliminary Menti results, and you guys seem to be coming from all over, so that's just terrific. I'd like to talk today about ways in which we can utilize GIS methods to understand timeliness and access to surgery, as well as some of the methodological challenges that we need to address in order to be able to use these methods effectively. So I'll divide my talk into three main portions. Number one, I'll introduce quickly the concept of GIS. I'll try not to overlap too much with Thiago's presentation. I'll introduce as well the 2-hour access concept. Then I'll spend some time presenting an overview of one of our recent articles where we try to validate some of these models in Rwanda. And then I'll end on describing some of the challenges I see for utilizing these methods in the most effective way going forward. So as you may know, depending on your familiarity with the Lancet Commission on Global Surgery, 2-hour access was chosen as one of the 6 core indicators. And the idea with these 6 indicators was that they would be relatively straightforward to measure, ideally, and that they would provide an overview of the surgical capabilities of nations and therefore allow comparison between different locales and also tracking over time. And the vision was that we would gather enough data for each of them so that they could be included in the World Bank World Development Indicators data set. And so 2-hour access specifically, it was defined as the percentage of the population of a country that can access a surgical facility capable of performing the so-called bellwether procedures within 2 hours. And the goal was that countries should strive for achieving 80% coverage by 2030. And so why 2 hours specifically? It was actually borrowed from earlier work in the maternal health community at the WHO, where it was recommended as a target for geographical distance for emergency obstetric services. It happens to represent the really rough time between onset of postpartum bleeding and death if no intervention is provided. So what are geographical information systems? Well, more broadly, they are software systems for dealing with spatial data of almost any kind. But for the purposes of calculating geographical access in general and 2-hour access in particular, basically what we do is we utilize information on things like the road network, the assumed speeds at which patients can travel on those roads. It may be inclination, it may be barriers to movement like rivers, the locations of hospitals, etc. Represented here by this. Can you see the pointer?
Yes, we can.
Yes, we see.
Okay. So represented here by this leftmost picture, this happens to be the network of major roads in Rwanda. And then that information is converted into what's called a travel time surface or an isochrone surface. Represented here, this is also Rwanda, where blue represents a short amount of time for getting to, in this case, a hospital capable of performing surgery. And then red represents a long amount of time. In this case, red is more than 2 hours. And then this travel time surface is combined with a population surface. And so basically what you do is you sum up all of the people living inside of the yellow and the blue, and you divide it by the total population, and what you get is an estimate of 2-hour access. And so GIS modeling has been quite extensively used in the global surgery literature. Here are just some examples. 2-hour access in Rwanda has been estimated to be between 96 and 100% in these 3 studies. I just lost my pointer, that's odd. 2-hour access to hospitals in sub-Saharan Africa has been estimated to be between 71 and 93%. Methods like these have also been used for national surgical planning or NSOPs. A problem has been that only 19 countries are actually reporting enough data on the surgical capabilities of the individual hospitals, such that it's possible to calculate 2-hour access as per the stricter Lancet criteria. But despite the fact that this type of methodology has been quite extensively used for both NSOPs and in the literature, there really has been quite limited validation in terms of are these are the GIS models reliable? Do they work in an LMIC setting? They've been extensively validated in high-income settings. And I think in our research group, we had a feeling or an inclination to believe that maybe these numbers were on the optimistic side. And so that brings us to the second part of my talk. What we did was we wanted to validate the GIS models against primary data collected from patients, so patient-reported travel times. We had this great team based in both Boston and Rwanda, and we presented this article. The aim of the article was, as I said, to compare GIS model estimates to patient-reported travel times. We were able to gather this data at the Kirehe District Hospital in southeastern Rwanda. We included a total of 664 patients who all underwent an emergency C-section during the study period in 2017 and 2018. And we gathered detailed information on their travel times in REDCap. And what we did is we asked them to estimate the time it took for them to get to the hospital, both in total, from getting from the home to their closest health center, from getting to the health center to the district hospital, and how long it took them to wait for an ambulance and so forth. Crucially, what we wanted to compare, though, was only the time spent on the road, because this is what a GIS model is trying to estimate. So if they went to a health center, it was decided that they needed an emergency ambulance, and then they had to wait for an hour for the ambulance. We didn't include the waiting time for the ambulance in the comparisons that I'll show you later. And so what we wanted to do was we wanted to measure the reliability of the GIS model that had been most extensively used at that time to calculate 2-hour access. In this model, roads are categorized into 3 categories: primary, secondary, and tertiary roads. And those types of roads are assigned speeds of 150 and 30 kilometers an hour, which is roughly 60, 30, and 20 miles per hour. And then wherever there isn't a road, patients are assumed to be walking at a speed of around 5 kilometers an hour or 3 miles per hour. And then rivers and lakes and such are taken as barriers to movement. And what we did is we constructed actually 2 models, both what we call the standard model, in which patients were assumed to travel the most direct route from their home to the district hospital. This is obviously the type of model that is, as far as I know, exclusively the type of model that is used in the literature that we wanted to assess. But we also did a modified analysis in which we assumed that we let the GIS model assume that the patient actually would be traveling the road that they actually traveled, which is in this district, at least, that they always actually had to go to the health center first before they could be referred to the district hospital. And so this graph, I think, represents our main result. In this graph, along the x-axis, each dot is a patient, and along the x-axis, you have the estimated travel time by the GIS model, and along the y-axis, you have the patient-reported travel time. And the dashed line represents a 1-to-1 ratio. So if the model was accurate and unbiased, you would assume that points would gather around the dashed line. And then you have the blue line, which is just linear regression. And what we see is that actually points are on average further up than the dashed line. And so that means that patient-reported times are on average higher than GIS estimated times, actually by almost 50%. And we can also present the travel time estimates graphically. This is a map of Kirehe district. The black dot that you see right here, that's the hospital. And then blue is a short amount of time and red is a long amount of time to get to the hospital. And you can see quite directly how GIS models work. and how much, everywhere you see sort of a blue line, that's a road. And then these black lines, those are rivers that don't have bridges that you can cross. And we can compare this picture to this one. On the right-hand side here, what you see is the average travel time as reported by patients. And so clearly there existed discrepancy here, right? But we also did this, what we call the modified model, where we broke up the journey that the patient took in the GIS model from the home to the health center, and then from the health center to the district hospital. And when we took that detour into account, what we found was that this blue line was much closer to the dashed line, i.e. the results were much less biased. And so I think the key takeaways for our team from this study was that GIS times, they correlated well with patient reported times, but they were biased. And they were significantly biased downwards. So the model that was being used in both the literature and in national surgical planning, it overestimated 2-hour access and geographical access. And in this setting, in this part of Rwanda, if you did even the relatively simple adjustment of accounting for the health center detour, that seemed to work quite well in order to yield more accurate results. With the caveat that we didn't include the waiting time for an ambulance. And in reality, obviously, the patient maybe did have to wait for an ambulance. And unfortunately, for data availability reasons, it just was not possible to perform that piece of analysis that would have allowed us to look at that as well. I'd like to spend the remainder of my time talking about some of the challenges for using GIS methods in global surgery. And my hope is really that some of you may have some valuable insights on how we can move forward in addressing some of these challenges. And I've tried to order them in order of roughly increasing intellectual complexity. So first, can we improve the accuracy of GIS models? And I think my answer to this personally is emphatically yes. We absolutely can improve the accuracy of used GIS models, but it will require no small amount of effort. If we want to quantify 2-hour access on a global scale and provide data for the World Development Indicators Database as per the Lancet Commission vision, we will need two things. We will need better travel speed data, and we will need better hospital location data. I think probably the most obvious solution for getting better travel speed data is that we would repeat the exercise we did in Rwanda in our team. And I know that other teams have followed us and done this in other locations as well, which is just to ask a bunch of patients, how long did it take you to get to the hospital? But then actually take one step further than we did, not stop at just comparing those results to a standard GIS model, but to actually use that data to derive a better one. The problem with this approach is that we would likely need to gather data from a multitude of different locales, and we would need to think very hard about which data do we use to generalize to, we can't gather data everywhere. That would be much too tedious. So how do we generalize the data such that it fits well everywhere? I think my personal opinion is, 150 and 30 kilometers an hour, that's probably too rough. But if on the other hand, if we were to use just the data from one district in Rwanda and we were to extrapolate that to all of sub-Saharan Africa or even to all of Rwanda, that wouldn't work either, probably. An alternative method that I've toyed around with, although I've personally not made any serious effort whatsoever to think harder about whether it would be viable, is to use a third-party service, like, for example, Google Maps. What they have, due to the large number of users of the Google Maps app on smartphones, is that they actually have quite detailed information on how long it takes in real life for people to get from point A to point B using different modes of transport that they are gathering every time you use the app. And it's possible to order this information from them. It's costly, but it's not more costly than gathering data from patients. Certainly not. And so that, could be an alternative approach. And as I've sort of toyed around with it myself, it seems as though it's actually fairly accurate. There are certainly downsides to that approach as well, in that when you construct the GIS model yourself, there are more advanced things that you can do with it. For example, as Thiago just showed us. And the second thing that we would need is we need better hospital data. And what that means in practice is we need an inventory of where hospitals are and what they can do. And we have a fairly good idea of where hospitals are. We have a fairly poor idea of what they can do. And so if we want to define 2-hour access on a global scale, I think this will be the most difficult thing. It will require a multinational effort of defining which hospitals can do what and compiling that in a central database. And so the second challenge, I think, hasn't really to do with how we perform the studies as much as how we communicate them. So I think it's important that we as researchers, that we understand and that we clearly communicate to the end users of the research, i.e. the policymakers, what a calculated 2-hour access actually means. And so you may be familiar with the 3 delays framework. It was referenced, for example, in the Lancet Commission. In this framework, the patient's journey from the need for care arising and they actually receiving the care, symptom to incision time, basically, it's divided up into 3 parts. So the first delay is a delay in seeking care, the delay on part of the patient. The second delay is the delay in reaching care, i.e. the time spent on the road. And then the third delay is the delay at the hospital. And all a GIS model ever really can do is it can only calculate the second delay. It's completely, you would need completely different types of methodology if you wanted to calculate the other types of delays. And so if we were to take GIS model outputs for 2-hour access at face value, which we shouldn't, but if we do, we are making a number of assumptions. So in terms of the first delay, the assumption that we are making, if we are taking it at face value, is that when the need arises, patient can start their travel right away. We know that the strength of this assumption is weak because we know that it's not true. An example of an unaccounted delay could be deciding to seek care, waiting for the ambulance, having to sell assets, etc. And the difficulty with trying to measure it directly is that it's highly context specific, but it's also, it could potentially be patient specific. The second assumption that we are doing is we are assuming that patients can travel at the declared speed in our model. We don't know the strength of this assumption. It's one of the things that we wanted to evaluate in the Rwanda study. Some examples of unaccounted delays could be poor road conditions. This could vary by season as well. We are also assuming that patients choose the fastest route. All GIS models do this. And this may also not be the case. And this is also one of the things that we wanted to try and look at in our study, and we found it to be not the case. And then for the third delay, the assumption, if we are taking the estimate at face value, is that upon arrival, there's capacity to take care of the patient right away. We don't know the strength of this assumption. It's difficult to quantify nationally. It's probably even difficult to quantify for a given hospital because it can vary by the time of the day. from one point to the other. It may be that the surgeon's busy, that the OR is busy, that the ER is overfilled, that there's a wrong decision in triage, etc. And so the third challenge is that there can exist a trade-off between centralizing and decentralizing care. I think this is something we are acutely aware of in both resource intense and resource poor settings. On the one hand, the more you decentralize, the better timeliness you have, the better geographical equity you have. On the other hand, centralization may lead to an improvement in surgical quality, certainly for low volume procedures. It could lead to better monetary efficiency. And so I think what we need to do going forward as a community is reach a consensus about which types of procedures do we want to be available under which timeframes. So for example, maybe we can define a set of a package of services and procedures that we want to be available within, for example, a 2-hour window, a 6-hour window, and a 24-hour window, just as a rough example. And really think about not just the emergency services, but the elective stuff as well. And I'll end on the most difficult question of all. I think not just for GIS methodology and global surgery, but for global surgery in general and for global health in general, is how can we move on from just describing inequity to actually using research to reduce inequity? And this is a question that I certainly do not have an easy answer to. Should we use GIS for advocacy purposes? Should we use it to derive indicator data? Is it best used in national surgical planning? Thiago mentioned an example of using GIS methodology for thinking about where we should place new facilities. How do we leverage the knowledge that we can gain using this methodology to actually improve care? And so in conclusion, GIS methodology it's quite extensively used in the global surgery literature. I think improvements both in terms of accuracy and in terms of coverage are absolutely needed, both for the individual articles, but also if we want to actually achieve the Lancet Commission idea that we can gather this and have it be a useful indicator for global surgery. And that if we want to use GIS methodology for planning the surgical scale-up, it will require a deep appreciation of both the limitations of the methodology, but also thinking really hard about the trade-off against other priorities other than timeliness. And that's it for me. Thank you very much.
Nick. Okay, I guess we're recording again. Thanks so much, Nick. Thank you. Seriously, I agree with you that it is very important to try to address the biases in geospatial analysis to reaching care by actual information from individuals or from the community, and also on the importance to remember to differentiate between physical access for all people within 2 hours, but also geographic access, considering the capacity of the health facility to actually provide care. So I'm really glad we had you speak to all of us. I also appreciate you kicking off the reflections already on how to improve GIS models. So I really look forward to our discussion and what some of our participants have to say. Allow me to quickly share the map. We've already pulled the results on where we are all dialing in from. And it is fairly impressive because we're really dialing in from all over the world. We're missing out on Australia, and Antarctica. But we're really dialing in from all over the world. I think we're very appreciative, of course, to our colleagues from Asia with a huge time difference. It's almost 12 hours, I think, to where we currently are. But obviously mindful and grateful to everyone who is dialing in from Europe, the African continent, South America, and also North America. I think, Beth, you put the Menti link once again in the chat. So all of you who haven't yet submitted the information where you're dialing in from, please let us know so that we can take that into consideration for further planning. And with that, let me kick off the discussion, the conversation. I think both presenters have shown complex realities on the ground, right? And how national and subnational aggregates, Brazil is huge. So even subnational is still oftentimes the size of a country. But how those national and subnational aggregates still hide health disparities, and thus really the need to go low and to look at the lowest level at which we can get information, patient information in the case of NICS research. So let me open for discussion. Let me ask you, you're both on video, so if you don't mind, maybe we can both you can both stay on video, so our participants can interact directly with you. A few points before we move into the discussion. If you do have a question, why don't you raise your virtual hand, or you can also place it in the chat. We can read it out from the chat. We can be monitoring the chat. We're very excited to be sharing the space together so that we can actually be informal among us. I think Thiago and Nick, we're both happy on doing it on a first name basis as well. But maybe when you do ask your question, introduce yourself briefly so that you know who you are and which institution you're representing, where you're coming in from. If you do want to turn on your video, that would be great, of course, so we can put a face to the name as well. But if that doesn't work, especially of bandwidth, that is absolutely fine too. As a privilege to the speakers, let me maybe allow first Nick and Thiago, you both, if you have a question or a comment to the research by the other speaker, to do so. And otherwise, invite you all to now raise your hands and or place your questions in the chat box. Maybe I'll start with Thiago. Is there anything that you would like to ask and or comment on NICS research?
One topic that is, I would like to highlight is very interesting, the approach to compare the data reported by the patient with the time displaced and estimated using GIS approach. So this is a very interesting and help us to kind of see how can we improve GIS models to kind of reflect the reality. And I agree with one of the topics that how can we improve GIS use in surgical care, not just in surgical care, how can we improve the use of GIS for healthcare domain? One topic highlighted by Nicholas was the need of a master list of facilities. This is something that is, without this information, there is no way that we can accurately estimate time displacement and distance and any other elements. And in terms of that, I would like to highlight that WHO releases 3 weeks ago, one effort, a global effort to kind of create a master list of health facilities. So they are right now working with this. The idea is to cover 59 countries up to the beginning of next year. And there are efforts in place exactly trying to create this master list because this is essential so we can identify lack of access, geographical barriers. And without this information, there's no way that we can be sure how to improve the healthcare networks across the globe. So congrats, Nicholas. I think that the effort that you are performing is very important in terms of how to improve GIS use. And I would just like to highlight this effort in place for WHO. Congratulations.
Thanks, Thiago. Nick, over to you.
Oh, Thiago, that's really, what did you, it was a WHO master list of healthcare facilities.
Yes, I can send you the exact name of the initiative. I don't have it right now, but they released this in a webinar 3 weeks ago, I think.
That's just terrific. I think, you know, we've been needing something of the sort absolutely for some time now, and it's great that it's happening under the WHO flag. I think that's definitely the right place for gathering such data. And there's also, so one of the articles that I referenced, the article by Uma et al. In, I believe, 2018 or 17, they gathered a list of all public hospitals in sub-Saharan Africa. But but the problem with that list in terms of using it for global surgery research is that we only knew that they were public hospitals and we didn't know what type of services they had. And I actually believe that the information's out there. It just isn't made easily available and compiled in a central database anywhere. And so, you know, it may be that for a large number of countries, it's actually fairly low-hanging fruit to try and gather the data on what type of capabilities are available at what locations. It will just require someone fairly stubborn to try and gather it. And thank you, Thiago, for your speech. I thought that was really interesting, and especially. I think it highlights that there are two things that we need to do. There's the more basic stuff that I showed of just gathering patient information, asking patients and asking hospitals what they can do. And then there's also the other thing that we need to develop, which is we need to develop our ability to do these more advanced geographical analysis that you've showed. And how we can really, I especially like the very last thing that you showed of using the network analysis, I think you called it, to figure out referral patterns and if we are to scale up, you know, service A in one hospital somewhere, where should we do that most optimally to optimize outcomes? And it's especially that type of work that we will need to develop to try and address this fourth and last question that I raised, is how do we really utilize GIS methodology to not just describe inequity, but to actually have actionable data so that we can improve outcomes for patients.
Thank you both so much. Allow me to bring in some questions from our audience as well. And just, I'm going to take advantage to having the mic and being the moderator, because there's so many thoughts that I have right now on the discussion that you had, because there was such a great opportunity with the 2020 census round of population housing censuses, right, that has been so majorly impacted by the pandemic, because so many countries in Latin America and the Caribbean, Thiago, 39 countries out of 42 have had to delay their census because of the pandemic, right? They couldn't go out and collect the information. Within the cartography of population health censuses, all man-made structures are basically being geo-referenced. And so we had a real opportunity to add so much more information on location of health facilities throughout that 2020 census round, which now is bearing the brand of the pandemic. And we're hoping to kick off in the next years or two to have that information. But just mindful that this pandemic has created so much of an impact on data collection and also on health facility, so that we're just mindful of the environment in which we're operating for such information as just location of health facilities, right? Let alone then the attributes and the capacities at all. But let me maybe just read out quickly what Leticia wrote from Brazil as well. I think it's a very important question that she's raising. What has been your experience with using the outcomes of your GIS related studies and applying them in health policies? Have you had any experience with negotiating with stakeholders in the sense? And then the second question as well from Hodan on to you, Nick. How can we integrate geospatial methods into existing studies? Do you have, or do you think using GIS is enough, or is it better to use GIS in other outcome studies as well? Maybe we'll start with you, Thiago.
Regarding Letitia's question, so we do have this experience, and for example, using the network analysis that I presented, we are right now developing a project with support of the Ministry of Health, exactly trying to use GIS approach to kind of support policy discussion. In Amazon, we have a challenge regarding snake biting information, and we don't have urban structure, we don't have roads. So how can we define to which locations we're gonna distribute anti-venom so we can cover the entire Amazon within 6 hours displacement. And we are converting the Amazon rivers into a routable network. What is a routable network? It's a network of transportation that you can use to define paths between two points, because this is the main transportation method used into the Amazon. So by using this, we geolocated where the snake bite envenomation cases are happening, and overlapping this, as Sabrina told, we have a challenge because the Brazilian census is 12 years outdated. And if you don't know where people are, how can you define how much people are going to need access? Where are present geographical barriers of access? And the strategy that we are using for this is one strategy used for micro planning of health campaigns that is using satellite estimated population. So we are using a population that is known as decimetric population. This population is created using satellite imagery with other elements overlapped, so you can define where people are. And we are overlapping these 3 layers: the network of transportation using rivers, the population extracted from satellite imagery, and where the snake bite envenomation cases are happening. So we can identify to which primary healthcare centers we can deploy antivenom. And by doing this, our aim is to cover the entire Amazon with 6 hours. And the advantage of using these GIS methods is that you can be much more precise to where you're going to deploy the new, where we're going to offer antivenom, considering this new network of facilities added to the current network. And you can be sure that most parts of the region will be covered. And this is exactly the type of evidence that policymakers want to decide what to do. So the result of the project, our expectation is to finish in kind of 6 months, is to define like summary report saying, okay, if you open if you offer antivenom in these new facilities, you're going to increase your population coverage in 25%. And you're going to be sure that most part of the population living to the Amazon region will be covered with a maximum displacement of 6 hours. By using this evidence, they can start discussing how to implement health policies to overcome these challenges. So if you offer the result of the analysis, the result of the process, in a way that the manager, the policymaker, or any stakeholder can understand what you're doing, they are very receptive to this type of evidence. So this is our experience.
Thank you, Tiago. Nick, would you have an answer? Would you have an answer to the question by Hodan as well that is posted in the chat?
So I think what you're asking, Hodan, and you'll have to correct me if I'm misunderstanding you, is should we try and perform studies like the one we did in Rwanda separately, or should we try and tack them on to other ongoing data gathering efforts that we have? Am I understanding you correctly?
Yes.
Okay, and I think I think yes, we absolutely. I mean, we need to always think about we always need to think about cost effectiveness in terms of what we're doing, and cost effectiveness in terms of, you know, how do we get the maximum actionable knowledge for our research dollars. And if we want to replicate what we did in Rwanda, it's only really a few questions, and it's fairly easy to add it to another ongoing data gathering effort. And it's in fact exactly what we did in Rwanda. The main point of asking patients question there had nothing to do with GIS, and we just realized, hey, we could also ask them, you know, a few extra questions and be able to produce this knowledge as well. And so I think, especially considering the issue of generalizability, that we want to be able to say something about geographical access in so many different locales, and derive a model that's working in different countries and in different contexts, we need to be able to gather data in a multitude of different settings. So that could be one way. Another way maybe could be to do something, you know, exclusively GIS focused. There's the Global Search Initiative and the Global Peat Search Initiative. That's been fairly successful. They've published a number of articles in which they have gathered a relatively small data set, but from many different places. And then they've had, 2,000 people be on the article list. But really they've been able, through doing that, to have a representation of, a huge amount of centers in the data set. So that could be another way.
Thank you, Nick. I think that was actually very straightforward. Rachel had to leave by now, so the last question actually goes to Carolina, and you will see that she posted her question in the chat as well, and I think it's directed to you, Nick. So maybe while you prepare your response, allow me to also give the floor one last time to Tiago for maybe 30-second, 1 minute last reflections that you would like to share with the audience today.
Thanks, Sabrina. I think that we have a huge amount of possibilities to apply GIS to overcome health challenges, and kind of disseminating how can we use this type of approach is something that is very important, because it's not very common to see researchers involved in healthcare domain using GIS techniques to trying to understand health-related problems. And I believe that by doing this, we can leverage the knowledge that we are producing regarding healthcare and improve quality of health for people. Thank you. Thanks, Nicholas. Thanks, Sabrina.
Thank you, Tiago. Nick, any last response and brief reflection before we close?
Well, I can maybe try to answer Carolina's question as a last remark, because I think it's a really good question, and it's a two-part question. So the first is, could it be that an explanation for the longer travel times be that they are in the Rwanda setting, that they are traveling via the health center? And absolutely, that's the case. And actually, when we accounted for that detour, the GIS model seemed to work quite well. With this caveat that they, in most cases, they had to wait for an ambulance. And I think if we had the data to take that into account as well, we would have probably a fairly different result. And then the second part of the question is, how should we, or how do we define 2 hours? Shouldn't it be between the time when we realize that the patient needs a surgical intervention, and isn't the start of that timing actually at the health center? I'm not sure. To begin with, I'd like to say that there's nothing magical about the number 2 as in 2 hours. It's somebody's idea from I think 20 years ago that this was the rough time from onset of postpartum bleeding to death. I'm not an obstetrician. I don't even know if that's accurate or not. Certainly for other types of surgical services, it could be that the optimal number is much lower. It could be 30 minutes as the optimal time. It could be 6 hours. I think in terms of having something to measure such that we can perform international comparison, it's just good to have a number around which there's some amount of consensus, and 2 hours is a fine limit for that consensus, and at least it's the one we've got, and it's unlikely that we'll change it. But I do think that the definition of the timing should be between onset of the need for care and delivering that care, whether delivering that care is trauma resuscitation, or skin incision in the OR, or getting medicines, what have you. Because that is the time that is actually going to affect outcomes, not necessarily the time between a decision and the start of the intervention.
Apologies, here I am. I got lost in my desktops. Thank you so much. I think both of you have actually answered many of the questions and addressed many of the difficulties as well. But I have to admit that especially the discussion now also kicked off further questions on definition and data sources and accuracy and information that we actually get from our analyses, that it just shows us that there's still so much to do. Allow me to thank you both, Nick, Thiago. Thank you very, very much for taking the time, for preparing the talks, for being with us today. Thank you all our participants who have stayed on with us throughout the discussions as well, and everybody who dialed in to be with us and share in on this conversation around geospatial for global surgery. With that, allow me to close and actually allow me not to close, allow me to invite you first to our event in May, and that is happening on the 12th of May. We will have 2 speakers discussing the burden of injury and presenting a systematic review, a systematic and a scoping review on the issue of the burden of injury. So the next event will take place on the 12th of May from 9 to 10:30 a.m. again. And we will share that information, but for you all to already know, you can also already go to our website, register for the seminar, and we look forward to having you back with us then. Thank you all. Thank you very much. Have a beautiful day or evening. Bye.